Welcome to the DeSera Clinical Education Psychiatry and Neurology podcast. I'm Lisa Phipps, Director of Scientific Services for Neuroscience here at DeSera Clinical Education, serving as your host today. I'm pleased to be here with Dr. Jonathan Meyer, Voluntary Clinical Professor at the University of California, San Diego, and Senior Academic Advisor of the California Department of State Hospitals. Today's podcast is part of our larger program on schizophrenia, titled Decoding Dual Action, Understanding Muscarinic Acetylcholine Receptors in Schizophrenia Management, and is supported by an independent educational grant from Bristol Myers Squibb. Hi, Jonathan. Thanks for being here with us today to impart some additional wisdom.
Hi, Lisa, and it's wonderful to be here.
At our recent Psychopharmacology Update conference, you did a marvelous talk on schizophrenia called Dopamine Detours, New Paths for Positive, Negative, and Cognitive Symptoms. This topic is so hot right now, we could have done an entire hour just on things people wonder about it. That being said, we're following up the talk with this podcast to continue the conversation, answering some of those additional questions and themes that continued to pop up. Let's dive right in. Naturally, we had a lot of questions about other disease states where this medication might be used, particularly others where psychosis or schizophrenia-like symptoms can occur. Let's chat briefly about those first. We were asked about schizoaffective, schizotypal, schizophreniform, delusional disorder, and also, of course, psychosis associated with substance use, Parkinson's disease, and Alzheimer's disease. I think that it would behoove us just quickly to differentiate schizoaffective, schizotypal, schizophreniform, delusional disorders, and talk about the treatments for those real quickly.
Yeah, so for one thing, schizotypal is a personality disorder. It is not a psychotic disorder, and therefore there really are no medications that are typically used for that. On the other hand, schizophreniform disorder really looks like schizophrenia. They typically haven't met the 6-month time point. Delusional disorder in some ways looks like schizophrenia only to the extent that they have positive symptoms in the form of delusions. Obviously, if they had hallucinations, they would now meet the criteria for schizophrenia. What we don't see as part of delusional disorder are negative symptoms or cognitive deficits, which is one way that distinguishes them. It's worth noting there's actually no FDA-approved treatments for delusional disorder, but as we'll get into, we really approach it as a chronic psychotic disorder. When I trained in the last century, we were taught that antipsychotics were not very effective for delusional disorder, but we've now come to the conclusion that it responds at about the same rates with second-generation antipsychotics as do people with schizophrenia, meaning, probably 2/3 of the people get some benefit. Substance-induced psychosis should be transient, should resolve on its own, and it's typically not a reason we would use chronic antipsychotic therapy. On the other hand, Parkinson's disease psychosis and psychosis associated with dementia, such as Alzheimer's disease, are areas where we do have a need for antipsychotic therapy. And importantly, as we'll talk about the mechanism of this drug, it's nice to have agents which do not have the burden of dopamine D2 blockade. For Parkinson's disease, of course, that would be completely intolerable, which is why the one FDA-approved treatment is pimavanserin, a drug which has no D2 binding. The other antipsychotic with a lot of evidence for Parkinson's disease psychosis is actually clozapine. Some people labor under the delusion that quetiapine is effective for Parkinson's disease psychosis, but most of the studies actually failed, and it's no longer given a high level of recommendation. So getting back to the whole concept of schizoaffective disorder, it really is schizophrenia, meaning these people will meet all the criteria for schizophrenia. Independently, though, they will have a predominant mood component. Sometimes it's just depression. Other times it may be a bipolar diathesis. I would just say as a clinician, there's actually very few things which are approved for schizoaffective disorder, but to be honest, we treat it just like schizophrenia in the sense that for the chronic psychotic component, we just use what we would normally use for schizophrenia. The big differentiator, though, is that those people who do have a bipolar diathesis typically need to be mood stabilized. And as many of you know, Our favorite mood stabilizer these days is lithium, always dosed once at night. Valproate, because of the enormous reproductive harms, is actually banned in most of Western Europe for women and also in some countries for men as well. And it's really an agent more and more to be avoided, especially for women of reproductive potential. So now getting back to the question, could we use the non-lane trospium for some of these individuals? Certainly for schizoaffective disorder, absolutely. Now, again, if they have a history of mania, they'll also need lithium on top of it. Schizophreniform disorder, well, we think these people mostly do have schizophrenia. They just haven't made it to the 6-month time point. And we would usually treat them like schizophrenia. Xanomeline trospium would be reasonable for that, all of course not approved, and neither is it approved for delusional disorder either. The advantages across many of these entities simply has to do with the fact that we're not going to get the side effects associated with dopamine blockade and all of its off-target problems, drug-induced movement disorders, endocrine disorders in particular, and some of the other things we don't like from these agents, such as weight gain and metabolic disturbance. There are trials ongoing right now for xanomeline trospium in people with dementia-related psychosis, and we'll see where those go. Obviously, the benefit is no movement disorders. The downside is one of the components is trospium, which is a strong anticholinergic. And when you give trospium to older men in particular, you have more concern about urinary retention. Now, the dosing will be different, and I think in the end, we'll just see where the data takes us.
Oh, wow. Okay. So more to come on that. And then, of course, as with all of our other new medications, people want to know about bipolar disorder. And we had people asking some specific questions. They had some specific cases, of course. I have a patient who has bipolar disorder, some with psychotic features, some without psychotic features. So people are asking naturally about bipolar disorder.
Well, again, I think we're talking specifically about bipolar 1 disorder because those are the people who develop mania with psychotic features. No data, and also there's no evidence, at least from preclinically, that xanomeline will have any antidepressant properties. The real question comes down to, does it have anti-manic properties? At present, that's unknown. It might. On the other hand, given the prolonged titration, it may not be the favorite drug one could use, even if it was approved for that in people with mania, because we will want something that we might be able to use very quickly. On the other hand, perhaps if there is data supporting its value in mania, it might be a nice drug as a maintenance, like we use other adjunctive atypicals, which only work on the manic pole as part of maintenance therapy. Right now, of course, not approved. And the question would be, could you get anyone to recover it? I think the answer is no. But I would stay tuned. As we get data which may emerge about the benefits of xanomeline for people with a history of mania, that'll certainly give us some impetus to use it more and more in people who have bipolar 1 disorder.
Do we have any data or do we know anything about, or do you have any opinions about any special populations? What about pediatrics, geriatrics, pregnancy, breastfeeding?
Yeah, so we have no data on pregnancy and lactation. And right now, the concern, of course, is the absence of data doesn't mean there's necessarily a problem, but it does pose some concerns and should be part of an informed discussion with a woman who becomes pregnant. That being said, what we've come to realize is that as a class, at least the other antipsychotics, the D2 binding agents, have not incurred a signal for major congenital malformations. And even if somebody was on a newer agent, newer being within the last 10 years, such as perhaps lorazepam or cariprazine, the feeling overall as a field, I would say, is that what keeps mom stable is probably the best for both mom and the baby. Now, that being said, xanomeline is a new agent, and we have less data, and I think it's a discussion that should be entertained for the first trimester if mom wishes perhaps to go to something else and then maybe switch back later on. And the same issue has to do with pregnancy as well as lactation. The difference is, of course, is the baby, if mom is on xanomeline trospium, will not incur dopamine blocking related adverse effects. On the other hand, there's trospium there, which may impair GI motility. And it's just something, because of the lack of information, we would say, if you feel like you wanted to stay on this and breastfeed, let's just keep an eye on the baby and observe her or him for any adverse effects. It doesn't mean we have to stop breastfeeding, although that's what it says in the package insert. But if mom wants to pursue it, I think you'd like to support her. But if baby does develop some adverse effects, often the way we manage that is not by stopping breastfeeding, it's but just reducing the amount of nutrition from breast milk from 100% perhaps to 75 or 50%, and thereby mitigating drug exposure. We would think xanomeline trospium would be a great drug for people who have adolescent onset schizophrenia, because think about it, Lisa, no weight gain, no risk that we can see for drug-induced movement disorders, no endocrine dysfunction. Sounds pretty appealing. We don't have FDA approval right now. We hope we might see that at some point, because from what I understand, you could have schizophrenia before the age of 18.
Yeah.
And lastly, for the older population, there are dose adjustments which are noted in the package insert. And they suggest that the maximum dose should be 100/20 milligrams BID. So below the max dose of 125/30 BID.
And so in geriatrics, like you said before, we want to watch the trospium, especially in older males, because of the urinary retention. So we might manage nausea differently in that population if they're taking it. And then I like what you said about the pediatrics and early onset schizophrenia, because we have, in our tardive dyskinesia talks, all of that information about higher risk and cumulative dose of antipsychotics for those folks. So that could be a really interesting place to go with this medication.
I work on a first episode program, and imagine you see somebody who's 18 years old and you can tell her, here's a medicine which has, as far as we can see, no risk for tardive dyskinesia or weight gain or endocrine problems. A lot of appeal there. And as we mentioned, you can have schizophrenia before the age of 18. It's very common
Yeah.
in late adolescence.
Hmm.
The downside, of course, is they have to take it. and that's
Yeah.
and that's something which people have asked about. Will there possibly be a long-acting injectable for xanomeline trospium? Well, maybe. How's that for an answer? Maybe.
Yeah.
There's a company out there, Terran Pharmaceuticals, which stated last year they're going to try to pursue it. Now, you can imagine the issues. Here's a 2-drug combo. Each of these has to be solubilized and injected and have the right pharmacokinetic properties. All I can say is maybe. It would be wonderful if we had it, given all the advantages we think of xanomeline trospium, not only for tolerability, but as we alluded to in the title of this program, for cognitive dysfunction, based upon the early signal that those with more significant cognitive deficits got some benefit. Not everyone, but a subgroup, and maybe even for negative symptoms. All I can say is cross your fingers, and maybe if we're lucky, you will have an LAI.
Yeah. Yeah. Also, of course, we had people asking about, can we use it in these different disease states? There are lots and lots of questions about, can we use it with other medications, and are there concerns about using it with other medications? The big one people asked a lot about was, can we use it with clozapine? And could it help with residual symptoms or partial control to add it in with patients who are already on clozapine? What might you do for patients on clozapine who are only partially controlled and still having symptoms? And all of those sorts of things.
Well, for one thing, for antipsychotics other than clozapine, there was an adjunctive study done. The acronym was ARISE, ARISE. They did specifically exclude antipsychotics which were considered anticholinergic, clozapine being the poster child of that, as well as also olanzapine and high-dose quetiapine. So those agents aside, they saw no safety concerns when combining xanomeline, trospium with aripiprazole, risperidone, paliperidone, all the other non-anticholinergic antipsychotics. Was there overall a benefit? The answer is no. For total symptom reduction, there were some subgroups that did benefit, especially those who were slightly less ill, meaning PANSS scores under 90, those on aripiprazole in particular. And there was a small numeric separation across all individuals for positive symptoms. I think the take-home message is use adjunctively, at least for those agents and people who are not resistant but still have residual symptoms. You may not see a huge benefit. I'm not saying you shouldn't do it, but there might be subgroups who do get a benefit for control of symptoms, especially positive symptoms. Now, getting back to clozapine, the question is, of course, is why are you giving them xanomeline to begin with? If they have residual positive symptoms, I think you have to understand a little bit about the biology of treatment-resistant schizophrenia. Reason that people are treatment resistant may relate to the fact that when we image these individuals, we do not see excessive dopamine production presynaptically the way we do for those who are not treatment resistant. For people who are resistant, postsynaptic D2 blockade, or in the case of xanomeline, presynaptic modulation of dopamine release makes perfect sense. They got a dopamine problem underlying their positive symptoms. For those who are resistant, though, we don't see that dopamine overproduction problem. And therefore, what you're asking is, will xanomeline somehow work in a pathway where we don't see a dopamine problem? And I think the answer might be no. And for those who are on clozapine who still have inadequate positive symptom control, let me give you a couple of thoughts. And this is based really on the fact that I work in a state hospital system in California, which has 7,000 patients, many of whom are resistant, a large fraction of whom are on clozapine. The first thing is get clozapine levels, try to maximize the value of clozapine. There is strong evidence that going up to clozapine plasma levels as high as 1,000 nanograms per ml is not unreasonable. Yes, you'll have to learn how to manage a lot of adverse effects and occasionally even seizures, but we think that for these people who are treatment resistant, clozapine is the only agent which has any hope of working. The other aspect, and this relates to those who might be schizoaffective bipolar type, is are these patients mood stabilized? If they have a history of mania, they should be. Now, let's say you came to me and said, okay, I got this guy, he's on clozapine. I pushed his plasma level up to 1,000 and he still has residual positive symptoms. And I've given him some D2 blockade in the form, let's say, of aripiprazole and low-dose risperidone, and he still has residual positive symptoms. Do I think xanomeline is going to make a difference? I think the answer is probably not. I think you've done whatever you can on that dopamine system. The other concern, and this has to do with the fact that trospium is a big component of xanomeline trospium, is that it's a strong anticholinergic. We know from the literature on clozapine that it itself has an issue with severe constipation and sometimes ileus, which rarely can be very serious. Adding trospium to that mix poses some serious concerns, both about ileus as well as about urinary retention. I think the point is that these people with resistant schizophrenia don't have a dopamine problem underlying their schizophrenia, in the idea that xanomeline, which works on the same pathway, although presynaptically it's a D2 blocker, will somehow make these people substantially better. It doesn't make a lot of biological sense. Now, if you had somebody who had cognitive deficits and you thought you wanted to get that benefit from xanomeline, I would say maybe, but you really, really have to know how to treat the GI motility issues that you might incur. So this is expert level stuff, and I'll be very cautious. And the flip side is, given our understanding of the biology of schizophrenia, specifically resistant schizophrenia, I would not necessarily encourage you also to take people off of clozapine so you could put them on xanomeline trospium. I don't think the evidence is supporting that. Now, if that changes in the future, and there's a dedicated study for resistant schizophrenia, maybe at that point, but we don't have that data. I think the biology of resistant schizophrenia would argue otherwise.
Let's see. Antidepressants was another one that came up as can we use xanomeline trospium with antidepressants?
Well, of course, it's never been studied, but there's no pharmacodynamic concern of note. The biggest issue is if the antidepressant is a strong 2D6 inhibitor. That's one contributor to xanomeline metabolism, which is quite complex, by the way. And in those instances, if you had somebody, let's say, on fluoxetine or bupropion, I would simply go a little bit slower and make sure the tolerability is there. That's the biggest concern, just the kinetic interaction, and specifically only those agents which are 2D6 inhibitors.
Okay. The other question we had was this new mechanism of action, which is talking about the cholinergic receptors and all of that sort of thing, has seemed to spark a lot of questions in several of our learners who are making this connection between the acetylcholine receptors and smoking. And they're asking questions like, why do patients with schizophrenia have such a high prevalence of smoking relative to the general population? Do you think it's at all related to any of this cholinergic regulation of dopamine? Could nicotinic receptors come into play in the future? All of that sort of thing. So, what are your thoughts about that?
Broadly speaking, there are two types of cholinergic receptors, one of which are nicotinic, which are ligand-gated ion channels, and the other are muscarinic, which are G protein coupled receptors. In terms of the biology of schizophrenia, there's occasionally some research which has looked at some polymorphisms of nicotinic receptors. We don't think it's a big contributor to the pathophysiology of schizophrenia broadly. Perhaps some polymorphisms may relate somewhat to cognitive dysfunction. But what we've come to appreciate as much as anything is that underlying the problems with cognition, in particular in people living with schizophrenia, are some deficits in the expression of muscarinic M1 receptors. And this is not true for everybody. We think, although cognitive dysfunction of schizophrenia is very common, maybe 80% or more, overall, 25% of people living with schizophrenia have very low muscarinic M1 expression, and that correlates with cognitive deficits as well as negative symptoms. Xanomeline works on both M1 and M4 receptors, and people have looked at polymorphisms for the M4 receptor. We don't think it's a big contributor to schizophrenia pathophysiology. I think the take-home message, as much as anything, is that we have found a way to modulate a system to improve the positive symptoms of schizophrenia with xanomeline, also cognitive deficits in the subgroup and maybe negative symptoms. And this is independent of smoking, meaning they studied people who were smoking. We didn't see any differential response. This drug works, meaning xanomeline, only on the muscarinic system. People have actually tried to find ways to target the nicotinic system, mostly to improve cognition, and those have all reached a dead end, unfortunately. And I think the point is that keep these systems separate in your mind. At least for now, we feel like targeting the muscarinic system has been really, really helpful to treat the positive symptoms of schizophrenia, possibly the cognitive deficits and maybe negative symptoms. And that's the future forward. And I think that's what's been very, very exciting. Now that we have an FDA-approved treatment, which is an M1, M4 agonist, really the question is, where does the field go from here in terms of developing other muscarinic strategies? And we'll talk about this in a second, Lisa, but one of the downsides, of course, of xanomeline, and the reason why there's trospium built into the combo, is that if I gave you xanomeline by itself, we got a lot of what we call procholinergic adverse effects, which was predominantly nausea and vomiting. And people have wondered, well, what if we get rid of the M1, which we think is probably the big offender in this, and just gave folks an M4 only strategy? How about that? Well, unfortunately, there's an M4 positive allosteric modulator called emraclidine, which was studied in two large phase 2 trials on the basis of a positive phase 1b study, and it didn't quite pan out. It doesn't mean an M4 only strategy is dead, because Neurocrine has an M4 compound and there might be others, but we will see. The hope is that it might work out, because maybe we don't have to worry about the procholinergic adverse effects. We will see. There's also other ways to target M1 and M4. A company called MapLight has a different compound, which is an M1, M4 agonist combined with a different peripheral anticholinergic. There are some people studying M1 only agents. Side effects aside, the idea is that maybe we can use the M1 specific agents for cognition, possibly negative symptoms. A lot of things are happening out there right now. There's a lot of companies who are looking at the muscarinic strategy. And all I can say, at least, is we'll just see where it goes over the next 5 years.
Sounds pretty exciting. Lots of stuff on the horizon. So, yeah, we mentioned those procholinergic effects, especially the nausea. And there, of course, were a lot of questions about mitigating that nausea and trospium versus ondansetron. And I know we talked a little bit during your talk about pushing the dose of xanomeline trospium, the combo, up to get that additional trospium on board as well, but that you can also just give extra trospium, but that there's also ondansetron out there. And so can you talk a little bit about your thoughts about treating with one or the other?
So, a couple of things we've learned over the last year since the initial approval is that there was an initial hope that keeping people on the 50/20 BID dose, maybe for more than a couple of days, might incur some tolerance to the procholinergic adverse effects. It hasn't quite panned out that way. And 50/20 BID, we don't think is therapeutic dose anyhow. The point is, at some point, you're going to have to move beyond that. Where we tended to see most of the procholinergic adverse effects was roughly about 5 days to a week after going to the higher dose of 100/20 BID. And it kind of makes sense. Before, I was on 50/20 BID, and now I've doubled the xanomeline exposure with no change in the trospium. And that's when people, if they were going to have a problem, tended to have it. It's worth noting that in the pivotal trials using the standard titration, only 15% did have an episode of vomiting. It was typically only one time when it did happen. It's not everybody, but people don't like it, and I understand that. In the clinical trials, they used ondansetron. And what I would say is it makes sense to have a conversation with somebody about some of these adverse effects and give everyone a prescription for ondansetron. If they're very, very nervous about the procholinergic adverse effects and they wanted to take ondansetron before every dose for a while, fine with me. But make sure they actually take it at least an hour before the xanomeline trospium to give it some time to work. One thing we do understand just mathematically is that when you get to the highest dose of 125/30 BID, we now have the maximum allowable trospium exposure, which is 60 milligrams per day. And one approach which needs to be discussed with patients is that if the 120 BID dose is simply intolerable with the ondansetron, we have a couple of options here. One is to go to the highest dose, which gives us 50% more trospium exposure. Now, there's a little bit more xanomeline exposure, but not nearly as much as the increase in the trospium exposure. Another option, which hasn't been studied formally but could be considered, is that if you're on 100/20 BID, that's 40 milligrams of trospium, the FDA max for daily trospium exposure is 60 milligrams. Perhaps rather than going up to the max dose, especially if the patient is very leery of that, I could give them an additional 20 milligrams of trospium, and it's available as a 20 milligram dose. You do have to be mindful, of course, that you're giving people more trospium. And as we talked about, older males in particular, you have to be a little more concerned about urinary retention. But for younger patients, it might be an option if they are reluctant to go up to the highest dose of 125/30 BID. Again, it has to be taken at least an hour before the dose because you want to get that trospium in there. It has to be taken on an empty stomach You lose all your trospium exposure if it's taken with food. It's good to know about this strategy. It might come into play for some people. I think the point is that you want to be flexible. You have to find ways to work with your patient and not insist that there's only one way to do things. We know how the titration went in the clinical trials, but if the patient says, I don't want to go up to the maximum dose, despite your explanations of pharmacology, you have to figure out another way to try to make this work, because as of today, we have no other muscarinic agonist available for the treatment of schizophrenia. That may not be true in 5 years, and we'll have other approaches. But for now, I think you want to use all the tools out there to try to get somebody over the hump, because once they're tolerant of this anomaly, we don't see ongoing issues. If it takes you a bit more time, if you have to be a little more flexible in the use of adjunctive agents, I think that's reasonable, because this is it right now. This is the only option in terms of a muscarinic agonist for schizophrenia, and it promises people enormous benefits, not only for tolerability, but also efficacy. One thing we didn't mention, Lisa, is that in the pivotal trials, their overall effect size was 0.65. And even if we reanalyze that data using an older mathematical concept, which is using the meta-analyses, we still get a number of 0.56. That's as high as we've seen for the last 30 years. This stuff really does work. It's not clozapine, but for non-resistant people, it works as well as anything we've ever had, really. And with all the advantages, not only in tolerability, but possibly also cognition and negative symptoms. The point is that this is it, and you want to find ways to get it to work.
I think one of the things that's so important also to remember is it's so counterintuitive, but you did say it, is it that this has to be taken without food. Otherwise, you lose all of the trospium. And it's so counterintuitive because oftentimes when medications cause nausea, we say, oh, take it with some crackers, take it with a little bit of food, something like that. And it's so counterintuitive that this one has to be taken without food. Otherwise, you're likely to make the nausea worse because you lose the medication that helps with the nausea.
This is a big point of education when you start this medicine. For one thing, you have to do the thing which many people don't want to do, which is to talk to your patient and have a conversation about their concerns regarding adverse effects. Some people are, I think, a little more sanguine, and the patient will say, well, I don't know, if I throw up, I'll call you, kind of a thing. Like, that's fine. Other people or their caregivers might be very concerned about nausea or vomiting and want you to do everything to mitigate that. Again, ondansetron liberally used, there's no downside. If they're really concerned, give them a prescription. I would give everyone a prescription for ondansetron, with the use of exogenous trospium only reserved for certain circumstances. But the big point of education is they must follow the instructions. They cannot take it with food, at least an hour before the first meal in the morning, which is usually when they get up, and at least 2 hours after an evening meal. Trospium is absorbed poorly even on an empty stomach. On an empty stomach, you only absorb roughly 10% of your trospium, maybe a little bit more. It's not much. And then, as you mentioned, Lisa, if you take it with food, of the little bit that normally will be absorbed, you lose 85 to 90% of that. And that's not going to be good for business. People have to know how to take this properly, because if they're not, it's not going to go well. That also has to be reinforced with the caregivers too, because they often may be controlling the timing of medication administration. In some group homes or boarding cares, dinner's given very early, like at 5 p.m., and they give the QHS meds right afterwards. Well, that's not going to be good. There needs to be at least a
Right.
2-hour separation. The way I encourage you to write the prescription is an hour before breakfast and 2 hours after dinner. Because if you write QHS, you have no idea how that's going to be operationalized. If you put at least 2 hours after dinner, I think it's hard to screw that up.
Yep. Yep. All right. Dr. Jonathan Meyer, let's finish up with one final question for you. What are you most excited about in this space right now?
I think I'm just excited overall about the possibility that we will have multiple muscarinic agents in the next 5 years, and ideally ones which perhaps might be a little bit easier to initiate than xanomeline trospium. That may not be true, and all I can say is we will see. But the idea that we could treat schizophrenia without incurring all of the off-target D2 blocking related adverse effects to me is just wonderful. And as a bonus, that we might benefit cognition in a subgroup of people, maybe even negative symptoms. I mean, these are all very exciting concepts. I mean, this is a revolution in the treatment of schizophrenia. And I think the idea is that maybe within our lifetime, perhaps sooner than later, we may have multiple strategies to help people. And if we're living well, maybe even an LAI.
That would be marvelous. Thank you so much for being with us today, Jonathan. And as always, thanks to our listeners for joining us. Remember to check out the show notes for more information on where to go for additional activities on this topic.